I'm Dr. Fakiraveri and this is Bacteremia in Adults. Here are some reliable resources for this topic. Infectious Diseases Society of America, or RDSA, provides guidelines, and we will focus on IDSA guidelines for bacteremia. First, in 2009, IDSA released guidelines for the diagnosis and management of intravascular catheter-related infections. Then in 2011, IDSA had specific guidelines for MRSA, or methicillin-resistant Staphylococcus aureus infections. This is a wide variety of infections due to MRSA, including bacteremia. So there is a section in there that's specific to bacteremia due to MRSA. There is also a consensus guidance that was published in 2020-21 for optimizing the management of uncomplicated gram-negative bloodstream infections. And more recently, IDSA has a guidance on the treatment of antimicrobial resistant gram-negative infections. The next learning objective is describe the common mechanisms of bacterial resistance to antibiotics. Wild-type bacteria are susceptible to many antibiotics, and they are called wild-type because they have not developed resistance through mutations or acquisition. However, they can still be resistant to some antibiotics intrinsically, and that's what determines the spectrum of activity of antibiotics. Resistant bacteria are the ones that are resistant to antibiotics that normally should have been susceptible to as wild-type. For example, wild-type Staphylococcus aureus is susceptible to penicillin, but you will see that many Staphylococcus aureus strains have developed resistance to penicillin. Wild-type Pseudomonas aeruginosa is intrinsically resistant to penicillin. Now, when bacteria develop resistance, not only can they pass these resistance genes when they divide, but they can also pass it to other species. The transfer of resistant genes occurs generally through 4 different mechanisms. Transformation is when naked DNA transfers from dying bacteria to a competent recipient. Transduction is the packaging of genes, usually from small plasmids, by transducing bacteriophages. One characteristic of bacteria is that in addition to their chromosome, they also have DNA as a circular DNA, which is referred to as plasmid. And this plasmid, because it's small in general compared to chromosome, it can easily be transferred to other bacteria. In conjugation, which is the most efficient way of transferring resistant genes to other species, self-transferable plasmids mediate direct contact by forming a mating bridge between cells. You can see in the picture in the right hand side the different steps of conjugation. Lastly, there can be conjugative transposition. You see, as opposed to chromosomes and plasmids, transposons are specialized sequences of DNA that possess their own recombination enzymes, allowing transposition or hopping from one location to another, independent of the recombinant enzymes of the host. Here are the common mechanisms of antibiotic resistance. Remember, for antibiotics to work, they need to get to the site of action. This provides several opportunities for the bacteria to prevent antibiotics from getting to the site of action. The first mechanism is reduced permeability. In this picture, we're looking at gram-negative bacteria with 2 membranes, so there's the inner and outer membrane. And for many antibiotics to get to the site of action, they need to penetrate through the outer membrane, often by going through a porine channel. So one thing that bacteria can do is to reduce the production of these porine channels, or in some cases even loss of porine production. And that will basically eliminate the channel of entry for antibiotics. There is also something referred to as biofilm, which we will discuss when we talk about bone and joint infections. Now, if the antibiotics manage to go through the outer membrane, some organisms can actually develop efflux pump and pump these antibiotics out. This is a common mechanism in Pseudomonas aeruginosa. Another mechanism is the change in antibiotic targets by mutation. So if the antibiotics do get to the site of action, then the site of action can mutate so that the antibiotic can no longer bind to the site of action. The fourth mechanism is modification of antibiotics itself. So there are beta-lactamases that can actually break down antibiotics. There are also aminoglycoside modifying enzymes that can basically alter aminoglycosides. And lastly, there is alteration of metabolic pathways. For example, the evasion of common pathway to make folic acid, which leads to resistance to trimethoprim sulfamethoxazole. Now, there are other mechanisms of resistance, but these are the common ones that we will focus on. Now, let's compare gram-positive and gram-negative bacteria. So on the left, we can see gram-positive, which only has the inner plasma membrane. There is no outer membrane. So on top of the membrane is the peptidoglycan layer. With gram-negative, there are two layers. So there's the inner and outer membrane, and between the two membranes, there is a small layer of peptidoglycan. Beta-lactams prevent the formation of peptidoglycan. So their site of action is where peptidoglycan is. So in order for the bacteria to make beta-lactamase and break down beta-lactams, they need to be made around the peptidoglycan layer. So you can see that for gram-positives, so this will be actually outside of the cell, whereas for gram-negatives, these beta-lactamases will be basically in the periplasmic space between the two membranes. This basically shows you that with gram-positives, they are likely to lose a lot of these beta-lactamases to the environment because there is nothing to hold all these beta-lactamases as they're being made by the bacteria. Whereas for gram-negative organisms, because of the outer membrane, they can hold on to beta-lactamases. So this is more cost efficient for gram-negative. So you will see that beta-lactamase production is a lot more common in gram-negatives compared to gram-positives. ESBLs are an important mechanism of resistance in gram-negative organisms. But before we can talk about ESBLs, let's consider what is a beta-lactamase. So beta-lactam ring is essentially a 4-member ring, and monobactams only have this 4-member ring, and penicillin, cephalosporins, and carbapenems have 2 rings fused together. And what some bacteria can do is that they can make a protein called beta-lactamase, which can essentially break down the beta-lactam ring, and by opening it, they will make the beta-lactam inactive, and that is a mechanism of resistance for them. And there are a lot of beta-lactamases out there. So there are penicillinases that can break down penicillins in general. And then, later on, when we brought cephalosporins to the market, bacteria learned how to make cephalosporinases, which can break down cephalosporins. And later, when we had carbapenems on the market, they learned how to make carbapenemases. And collectively, these are all referred to as beta-lactamases. And of course, to fight that, we also made beta-lactamase inhibitors. And what beta-lactamase inhibitors are essentially compounds that look like a beta-lactam ring, so that they have affinity for these enzymes that bacteria make. And by binding to the beta-lactamase inhibitors essentially make this inactive, so that these beta-lactamases can no longer inactivate the actual beta-lactam, so the beta-lactam can remain active and kill the bacteria. And we have quite a few of them on the market now. We have clavulanic acid, tazobactam, sulbactam, avibactam, weberbactam, and more recently, relibactam. Now, what exactly are ESBLs, or extended spectrum beta-lactamases? So these are the enzymes that can hydrolyze extended spectrum cephalosporins and monobactams. And extended spectrum cephalosporins are essentially 3rd generation cephalosporins, such as ceftriaxone. And they do not hydrolyze cefamycin, so cefamycin are a subset of 2nd generation cephalosporins, and they can also not hydrolyze carbapenems. Now, ESBLs are susceptible to most beta-lactams with the exception of sulbactam. So sulbactam does not have good activity or affinity against ESBL. Now, the CDC antibiotic resistance threats in the United States document lists germs into one of three categories, either urgent, serious, or concerning. For ESBLs, the CDC has labeled these as serious threat, so this is in the middle, as they are attributed to increasing cases and significant mortality in the US. In fact, when you see year by year, the number of cases of ESBL infections has been increasing year after year. ESBL producing Enterobacterales often cause infections in otherwise healthy people. So anybody could get these infections, and about a quarter of patients with these infections had no known underlying health conditions. Now, antibiotic options to treat ESBL producing Enterobacterales infections are limited, and healthcare providers often need to use IV carbapenem antibiotics for infections that otherwise could have been treated with oral antibiotics. So that increases number of patients who need to be in the hospital setting. Now, there are hundreds of beta-lactamases out there. So it's really difficult to study and see what's clinically significant. So the Ambler molecular classification of beta-lactamases, which was introduced back in 1969, it's not perfect, but it's perhaps one of the simplest ways to look at beta-lactamases, because it essentially breaks them into four classes. So class A, class B, class C, and class D. Class A, which is a large class, is a bit tricky because it has several subclasses. So this includes penicillinases that break down penicillins, and cephalosporinases that will break down first and second generation cephalosporins. And these can either be genes on chromosomes or plasmid. For Enterobacterales is most commonly on plasmids. Some examples are TEM1 and SHEV1. But what's really clinically significant is the ESBLs that we just covered. So ESBLs, and again, there are many enzymes under the subclass of ESBLs, and these are most often on plasmids, but they can also be on chromosome. But what's clinically significant is essentially the ESBLs that resides on plasmids. And in general, ESBLs can be broken into four categories of either TEM-derived. So essentially these TEM1 mutations over time have led to TEM-derived versions of ESBLs, as well as SHEV-derived. So mutations to SHEV1 over time has led to many descendants of this enzyme that are under ESBLs now. But the most common enzyme under ESBL is the CTX-M. So CTX-M is what's most common in the US and worldwide. And as part of class A, we also have carbapenemases. And before I mention this, let me go back to ESBL. So ESBLs essentially not only break down, extended spectrum cephalosporinases, so third generation cephalosporins, but they will also break down penicillins and first and second generation cephalosporins. And then when you look at carbapenemases, even though the name says it breaks down carbapenems, but these enzymes also break down penicillins and cephalosporins as well as carbapenems. So KPC is the most common enzyme in the US. Now, when it comes to class B, these are the metallobeta-lactamases. Essentially, class A, C, and D are based on serine residue at the active site of the beta-lactamases. With class B, these are essentially based on using zinc to break the amide bind. So these are called metallobeta-lactamases, and these are perhaps the most resistant organisms when they have metallobeta-lactamases. So some examples are IMP, WIM, and NDM. Class C, which is essentially AMP-C for the most part, and there are other enzymes in this class, was the most clinically relevant is AMP-C, and these essentially break down cephalosporins, but they can also break down penicillins and penicillins. And these AMP-Cs, they are stable to cefepime, so it cannot break down cefepime, but also they are stable to carbapenems. So they cannot break down any carbapenems, including imipenem, meropenem, doripenem, and ertapenem. And lastly, we have class D, which can include ESBL. So there are some OXA type ESBLs, but also most of these are carbapenemases. So a lot of, there are various numbers of OXA enzymes, and most of them are carbapenemases. And, they break down penicillins, cephalosporins, as well as carbapenems. And of course, because we have all these beta-lactamases, we have also developed beta-lactamase inhibitors. So we have several beta-lactamase inhibitors on the market. So classically, we have clavulanic acid, which is actually a natural product. And it can essentially inhibit TEM enzymes, SHEV enzymes, and CTX-M. Has no activity against class B, C, or D beta-lactamases. Then we have sulbactam, which is not the best for ESBL, so it doesn't have good activity against CTX-M. It has some activity against TEM and SHEV. Does not have activity against class B, C, or D. But most importantly about sulbactam, it has, unrelated to beta-lactamases, it has intrinsic activity as an antibiotic against Acinetobacter baumannii. Tazobactam also can inhibit ESBLs, including CTX-M, but no activity against class B, C, and D. Enmetazobactam is a derivative of tazobactam, so it has improved potency against ESBLs. That's what it's designed for, so better activity against CTX-M ESBLs. No activity against class B or C, and there's limited data for class D. It may have some activity against some OXAs, but right now there is limited data. Then we have avibactam, which has really good activity against class A, including ESBLs as well as KPC. So these are, carbapenemases. So avibactam can restore activity against carbapenem-resistant Enterobacterialis. Does not have activity against class B, but also stable against class C, MC, and OXA48. So OXA48 is inhibited by avibactam. Relibactam, also good activity against ESBLs and KPC, as well as AMP-C, and limited activity against OXA class D enzymes. Durlobactam, also excellent activity against ESBLs and KPC, AMP-C, and a large variety of OXA enzymes in class D. Weberbactam, great activity against ESBLs and KPC and AMP-C. And lastly, taniborbactam, which as of this recording still under development. It is not on the market yet. It has activity against ESBLs and KPC. It has activity against some class B. So this is the first time we have a beta-lactamase inhibitors that may inhibit some of the common class B. And it's not all of class B. So there is, for example, IMP that's not inhibited by this, but certainly NDM and VIM are. It also inhibits AMP-C and has activity against OXA48. Now let's take a look at these beta-lactamases in another way. So essentially beta-lactamases, you can think of them as serine beta-lactamases or metallo-beta-lactamases. Metallo-beta-lactamase, which is the worst type of beta-lactamases. These are amyloid class B. These are carbapenemases that break down carbapenem, cephalosporins, and penicillins. Some examples include IMP, NDM, and VIM. And we don't really have anything on the market as far as beta-lactamase inhibitors. Taniborbactam is under development that could inhibit some of these. For serine beta-lactamases, we have amyloid class A, which includes the narrow spectrum like TEM1 and SHEV1. These are the ones that inhibit penicillins and first or second generation cephalosporins, and they're essentially inhibited by all beta-lactamase inhibitors that we have. Then we have ESBLs, and most commonly is CTX-M. These are inhibited by most of beta-lactamases we have except sulbactam. And then the worst type of class A is carbapenemases, so KPC is the most common one, and that's inhibited by some of the broad spectrum beta-lactamase inhibitors, namely avibactam, relibactam, durlobactam, weberbactam, and taniborbactam. With class C, which these are cephalosporinases that also break down penicillins, these are inhibited by avibactam, relibactam, durlobactam, weberbactam, and taniborbactam. And lastly, we have class D, which are carbapenemases, and these are oxa types. That includes some ESBLs, but most of them are carbapenemases. So carbapenemases, they will break down penicillin, cephalosporins, as well as carbapenems. Most common one is OXA48, and OXA48 specifically is inhibited by avibactam and taniborbactam, and durlobactam is unique in the sense that it can inhibit most of OXA type enzymes. Let's take a look at Staphylococcus aureus. So Staphylococcus aureus can be divided based on its pattern of resistance. So the wild type, which is basically penicillin susceptible, is constituting less than 10% of the isolates nowadays. Then we have MSSA, which is methicillin susceptible. MSSA is resistant to penicillin. Then we have methicillin resistant, so MRSA, and the drug of choice for MRSA is vancomycin. Now, while very rare in the United States, there is also vancomycin intermediate Staphylococcus aureus, or VISA, and that is basically that Staph aureus is no longer susceptible to vancomycin, but the MICs happen to be in the intermediate range. And then we have Staphylococcus aureus with MICs in the resistant range for vancomycin, which is referred to as VRSA. Now, MRSA is clinically important, and in general, there are different types of it. So we have healthcare-associated MRSA, and then we have community-associated MRSA. Now, there's also livestock-associated MRSA based on the antibiotics that are used in animals and in food production. But clinically, we basically break these down into healthcare-associated MRSA or community-associated MRSA. And healthcare-associated is the more common strain, which most healthcare professionals encounter. And this strain is resistant to beta-lactams, with the exception of ceftaroline, and several other classes, making preferred therapy more broad-spectrum agents. Now, community-acquired MRSA is strain only found in the community, and other classes other than beta-lactams are still possibly active against these, so such as like doxycycline, moxifloxacin, trimethoprim sulfamethoxazole. Now, something of note is that the resistance genes that make Staphylococcus aureus resistant to methicillin is the MECA gene, which can be identified on rapid diagnostics. And this is the gene responsible for alterations in penicillin binding protein 2A, and that is the target site for methicillin class. So napsilin and oxacillin, as well as cefazolin, they bind to the site. So when there is mutation, alteration in this, they no longer can bind to penicillin binding 2A, which makes it resistant to that class. MRSA is also considered a serious threat by the CDC, but the good news is that it seems that the number of cases year after year are declining, and in recent time it may have stabilized. The issue is that MRSA has become resistant to many first-line antibiotics, specifically oral antibiotics that we may have for less serious infections. And people who inject drugs are 16 times more likely to develop a serious MRSA infection than those who do not. Enterococcus species, which are gram-positive, can develop resistance to aminoglycoside in 25 to 50% of the isolates. And these are basically plasmid-mediated resistance that are aminoglycoside modifying enzymes. And of course, there is vancomycin resistant enterococcus, or VRE, and there are two main genes that make VRE, so VAN-A and VAN-B, both of which can be identified with rapid diagnostic tests. And basically, the site of action for vancomycin is the alanine D-alanine, and what happens in enterococcus with these genes is that basically it mutates and changes the second alanine to a lactate, and as a result, vancomycin can no longer bind to the alanyl D-lactate. And this mutation basically does not interrupt the life cycle of Enterococcus. So Enterococcus at this point will be VRE. It continues to replicate, and vancomycin will be ineffective. Now, Enterococcus is part of the human flora, so it is common for people to be colonized with VRE, and that's something that can be detected by screening tools on the stool sample. Vancomycin-resistant enterococci, or VRE, are also considered a serious threat by the CDC. You can see that year after year, the number of cases have been going up. However, in recent time, the number of cases may be going back up again. And about 30% of all healthcare-associated enterococcal infections are VRE, and nearly all VRE infections happen in patients with healthcare exposures as opposed to happening in the community setting. VRE is increasingly resistant to additional antibiotics, raising concern that the remaining drugs to treat VRE may become less effective. Lastly, let's take a look at E. coli. So E. coli is a gram-negative rod, and it can be resistant to many antibiotics, so including resistant to beta-lactams, and it's primarily through various beta-lactamase production. So including some strains can be ESBL producing, as well as KPC, which is a carbapenemase, as well as OXA48, which is a carbapenemase, and of course the whole subclass of metallo-beta-lactamases that are carbapenemases. So E. coli can be very resistant. At the same time, a wild type E. coli can be pan-sensitive to many antibiotics. Now, trimethoprim sulfamethoxazole resistance is basically increasing, and it is due to overproduction of dihydrofolate reductase. So dihydrofolate reductase is the site of action for trimethoprim, as well as mutations in the gene DHPS is the site of action for sulfonamide, so sulfamethoxazole. Fluoroquinolone resistance can be due to polymorphisms in the GIR-A, which is a gyrase, the gene for the gyrase, and basically that's the site of action for fluoroquinolones such as ciprofloxacin. Tetracycline resistance can be induced by expression of efflux pump, which is encoded on the TET genes. We described the common mechanisms of bacterial resistance to antibiotics. Now let's explain the mechanism of action and spectrum of activity of glycopeptide, lipopeptide, and beta-lactam antibiotics. There are 4 classes of beta-lactams. There are penicillins, cephalosporins, carbapenems, and monobactams. And they are all bactericidal. What bactericidal means is that they actually kill the bacteria very fast. So as time goes forward, the number of colonies actually drop very quickly. As opposed to bacteriostatic agents that don't necessarily drop the number of colonies, but actually halt the growth of bacteria. So the number of colonies actually stay the same over time. Beta-lactams bind to penicillin binding proteins, or PBP. And there are different types of penicillin binding proteins which result in different spectrum of activity of beta-lactam antibiotics. Now, the first beta-lactams are penicillins, so these enzymes were named after the first beta-lactams, so they are called penicillin binding protein, but they are also known as transpeptidase. And transpeptidase is an important part of cell wall synthesis. So by inhibiting penicillin binding protein or transpeptidase, beta-lactams inhibit cell wall synthesis. Now, without going into too much detail, the synthesis of peptidoglycan involves several steps, and one crucial step is the cross-linking of components of peptidoglycan, and that cross-linking is done by transpeptidase enzymes, and that is the site of action of beta-lactams. Let's take a look at the spectrum of activity of penicillins and monobactams first. So when it comes to penicillins, these are there are essentially subclasses of penicillins. So the first penicillins to come to the markets were actually called penicillin, and we have 2 different forms, penicillin G and penicillin V, with identical activity. And these have good activity against beta hemolytic strep, but they may not have the best activity against Streptococcus pneumoniae. Now they are active against most E. faecalis, but they have no activity against Enterococcus faecium, and they are not active against any Staphylococcus aureus. So MSSA and MRSA are not active. There is a small subset of Staphylococcus aureus called penicillin susceptible Staph aureus that these agents are active against, but those are essentially less than 10% of all Staphylococcus aureus. And the reason is that majority of Staphylococcus aureus actually produce penicillinases that break down penicillin, so they don't have activity against MSSA or MRSA. And they don't have any activity against gram-negatives as well as anaerobes or atypical organisms. Now the next set of penicillins are referred to as anti-staphylococcal penicillins. So these are nafcillin, oxacillin, dicloxacillin. So these are colored the same just to help you navigate this chart. So the three have identical spectrum of activity. Now they are called anti-staphylococcal penicillins because they have activity against MSSA. However, they are not active against MRSA. In fact, none of the penicillins are active against MRSA. Now, when these became stable against MSSA, it came at the cost of losing some of the activity, including they lost activity against E. faecalis, and they had generally poor activity against beta-hemolytic strep and strep pneumo. Now, the next set is aminopenicillin. So this is ampicillin and amoxicillin, which have identical spectrum of coverage. Ampicillin and amoxicillin, they do have improved gram-negative activity compared to the previous subclasses of penicillin. So they get some activity against H. flu and including E. coli, Klebsiella, and protease. But it comes at a cost because they lost activity against MSSA because they are no longer active or stable against penicillinases that Staph aureus makes. Now they do have activity against beta-hemolytic strep and E. faecalis and somewhat against strep pneumo. Now by adding beta-lactamase inhibitors to these two, so now if you combine ampicillin to sulbactam and amoxicillin with clavulanate, you gain some of these activity. So now the penicillinases from Staphylococcus aureus are neutralized by these beta-lactamase inhibitors. So ampicillin, sulbactam, and amoxicillin clavulanate are active against MSSA, and they do gain better activity for gram-negative organisms. And more importantly, they also gain activity against Bacteroides, which are anaerobic organisms. Okay, so Bacteroides also make penicillinases that pretty much kill majority of penicillins, but the ones that have beta-lactamase inhibitor, including piperacillin tazobactam, they gain activity against Bacteroides. Now, Bacteroides become very important when we talk about intra-abdominal infections. Now, the last and the broadest penicillin is piperacillin tazobactam, so excellent activity against beta-hemolytic strep, against strep pneumo, as well as E. faecalis, but not against E. faecium. It does have activity against MSSA, but not MRSA, and pretty good gram-negative coverage overall. But more importantly, this is the only the only penicillin that has activity against Pseudomonas aeruginosa. Lastly, pivmesillinam is an oral aminopenicillin that has become available in the US in recent years, and you will see that it's significantly different than the ampicillin and amoxicillin in the sense that it doesn't have activity against gram-positives, and it's really used for treatment of urinary tract infection. It has excellent activity against E. coli and organisms that are most likely to cause urinary tract infections, so it's really used for that. Now let's take a look at monobactams. Aztreonam is the only monobactam that's available in the US, and it is also available in combination with beta-lactamase inhibitor avibactam. You will see that they absolutely do not have any activity against gram-positives, so that's extremely important to keep in mind anytime you use Aztreonam as part of your regimen, that it does not have any gram-positive coverage. It has excellent coverage against some of the gram-negative, such as H. flu, and some of the enterobacteriales, such as E. coli and Klebsiella. And it really has somewhat poor activity against Pseudomonas, and its activity has declined over the years. So really, it's not the best option for empiric treatment of Pseudomonas infections. But when susceptibility results are available, that's fine to use. And adding avibactam doesn't really restore activity against Pseudomonas, but it does make Aztreonam avibactam excellent against beta-lactamase producing enterobacteriales, especially if it's a class B metallo-beta-lactamases. Now let's take a look at cephalosporins. We have a lot of cephalosporins on the market. These are select few that are more commonly encountered, but there are a lot more. And cephalosporins in general are thought of in generations. So there is first generation, second generation, third generation, and fourth generation. And then at some point we kind of stopped calling generations because it started to be inconsistent. Now, in general, you go from low, narrow spectrum to broad spectrum as you go higher with the generations. So we have for the first generation, cefazolin and cephalexin. They have essentially identical spectrum of coverage, so good activity against beta hemolytic, somewhat activity against strep pneumo, and nothing against enterococcus species. And they do have activity against MSSA, so even though Staphylococcus aureus makes penicillinases, it cannot break down cephalosporin, so this is active, but they do not have activity against MRSA. In fact, ceftaroline is the only beta-lactam in general that has activity against MRSA in the US among the agents that are available in the US. There are other beta-lactams that are available elsewhere that may have activity against MRSA. Now for gram-negative, first generation, they have somewhat activity against E. coli, Klebsiella, and protease, but you typically need susceptibility results to confirm, and they don't have activity against Pseudomonas, Bacteroides, or atypicals. Now when we go to second generation, again, it's important to note that there is a subset of second generation referred to as cefamycin, so that's cefoxitin and cefotetan. And the rest of second generations, one example is cefuroxime. Cefuroxime has good activity against beta hemolytic, but not strep pneumo. And again, all of them are good with MSSA. When it comes to gram-negative, cefamycins have improved activity against gram-negatives, especially some of the enterobacteriales. And cefamycins also have activity against Bacteroides, so that's unique. When you look at cephalosporins, none of them have activity against Bacteroides except for the two cefamycins that we have. Now, third generation cephalosporins, you will see we have the first three are oral, and then we have the IV formulations. So in general, somewhat good activity against gram-positive organisms. And then when you go to gram-negatives, in general, they have pretty good activity against gram-negative organisms, but they are not active against Pseudomonas except ceftazidime. So ceftazidime is the only member of the third generation cephalosporins which has activity against Pseudomonas aeruginosa, and it has a very good activity, ceftazidime. When it comes to fourth generation, cefepime is the only fourth generation we have, and the unique thing about it is again Pseudomonas, excellent Pseudomonas activity, and it also has good gram-positive activity, so beta hemolytic, strep pneumo, and MSSA. And ceftaroline, which some people would call it fifth generation, and others would call it anti-MRSA cephalosporin. because it's the only cephalosporin in the US with MRSA activity, and it's also has activity against efficalus, and good activity against gram negatives, but the only hole in it when it comes to gram negatives is that it does not cover Pseudomonas. So that's one shortcoming of ceftaroline. Ceftobiprole is unique in the sense that it is the only beta-lactam that covers both MRSA and Pseudomonas. So you can kind of think of it as ceftaroline with Pseudomonal coverage. And more recently, we had cefiderocol come to the market, and just like aztreonam, cefiderocol does not have activity against any gram-positive, but it has perhaps the best activity against gram-negative. So it pretty much covers anything that's gram-negative that's clinically important, including Pseudomonas and Acinetobacter. Pretty much majority of these beta-lactams are not good against Acinetobacter. Cefiderocol has good activity. So cefiderocol is a novel siderophore cephalosporin. It is still considered a beta-lactam, but so it does bind to penicillin binding protein, but it's somewhat unique because the way that it enters the cell is that it hijacks the siderophore that comes with the bacteria. So what the siderophores do, they're actually natural iron chelating molecules that are released by bacteria to facilitate the transport of iron into cell for survival. So bacteria do need iron to go into their cell, and what cefiderocol does is that it hijacks. So it's kind of like a Trojan horse, and it hijacks the system to find entry into get entry across the outer membrane so that it can bind to penicillin binding protein. And this is kind of neat because it can overcome some of the mechanisms of resistance in gram negative. So because it doesn't depend on porin channels to enter outer membrane, it doesn't matter if the bacteria make changes in porin channels. And it's also somewhat stable to efflux pumps. So, that's the reason for its excellent activity against many gram-negative organisms. And to make it even better, its structure is stable against hydrolysis by many beta-lactamases, including metallo-beta-lactamases. So remember, when it comes to metallo-beta-lactamases, these are amyler class B. They pretty much break down all of the beta-lactams, and none of our beta-lactamase inhibitors can block these. Now, cefiderocol is actually stable against metallo-beta-lactamases, meaning metallo-beta-lactamases cannot break down cefiderocol. So here's a figure that it shows you how cefiderocol goes across the outer membrane into the periplasm space where it can bind to penicillin binding protein. So essentially it hijacks the system where the bacteria is trying to bring iron in, and cefiderocol hijacks the system and goes in and finds penicillin binding protein. Now let's take a look at the spectrum of activity of carbapenems and cephalosporins. So essentially we have ertapenem, which has a narrower spectrum of activity compared to other carbapenems, and the reason is ertapenem does not have activity against Pseudomonas, so it's somewhat narrower compared to the rest of them. Now all of them are active against Bacteroides, and all of them are active against MSSA, but none of them are active against MRSA. Imipenem has really good activity against pretty much most of the clinically important organisms, including Pseudomonas. It's also active against efficalus. With meropenem and doripenem, pretty much identical to imipenem with the exception of efficalus. They are not active against efficalus. Now, more recently, we have added beta-lactamase inhibitors to meropenem and imipenem to overcome some of the carbapenemases that are made by Enterobacterialis. So you will see that the spectrum of activity in this table looks the same, but essentially the advantage of these two is that things like E. coli and Klebsiella, if they happen to make carbapenemases, then meropenem and imipenem will no longer be active, and these can potentially overcome those mechanisms of resistance. And in the case of imipenem, because imipenem alone is not stable to AMP-C, if there happens to be an organism such as Pseudomonas that makes AMP-C, then lipopeptide can block AMP-C so that imipenem will continue to have activity. So when you compare meropenem, beta-lactam, and imipenem, lipopeptide, the role of imipenem, lipopeptide would be that extra activity against Pseudomonas. Otherwise, they both have good activity against carbapenem-resistant Enterobacterales. And lastly, we have cephalosporin combinations with some beta-lactamase inhibitor. So we have ceftolozane, tazobactam. So ceftolozane is kind of similar to cefepime, but it's not available alone. So it was not listed in the previous table. It's only available in combination with tazobactam. So, in general, not much activity for gram-positives, but it has good activity against gram-negatives, particularly for Pseudomonas. So the reason they developed ceftolozane tazobactam was really to target Pseudomonas that were potentially resistant to other available agents. So if you have Pseudomonas resistant to cefepime and, piperacillin tazobactam, or even resistant to carbapenems, if you have Pseudomonas resistant to meropenem, ceftolozane tazobactam could potentially still have activity, so very potent against Pseudomonas. And of course, ceftazidime alone was active against Pseudomonas, and in combination with avibactam, it really has become a potent agent against carbapenem-resistant Enterobacterales, so CRE. So some of those E. coli and Klebsiella that make carbapenemases, ceftazidime, avibactam could potentially be active against those. So, and ceftazidime, avibactam came to the market before we had meropenem, beta-lactam, and imipenem, lipopeptide. So it really had a big role in when we had Enterobacterales that were resistant to carbapenems. Ceftazidime, avibactam would have been the only drug of choice at the time. But nowadays we have these carbapenem combinations with beta-lactamase inhibitors. So we have several options now for carbapenem-resistant Enterobacterales. Cefepime and tazobactam essentially has the same spectrum of activity as cefepime. The only addition is that tazobactam makes cefepime stable against ESBL. So when it comes to Enterobacterales, so E. coli, Klebsiella, etc., if they have ESBL production, cefepime will be stable to it. So it has improved activity for these gram-negative agents. Now let's talk about glycopeptides and lipoglycopeptides. So vancomycin is a tricyclic glycopeptide. It is a huge molecule. So you can see a depiction of its chemical structure. And these are bactericidal agents, but they are relatively slow acting. And they bind to the C-terminal diallo residue of the pentapeptide cell wall building block, and thereby they inhibit cell wall synthesis. Now, vancomycin is the primary glycopeptide used in the US, and there are lipoglycopeptides that are derived from vancomycin's structure. So vancomycin's spectrum of activity is pretty much geared towards gram-positive, so excellent activity against beta-hemolytic strep pneumo, Ephicalis, although some poor activity against Ephysium. The large majority of Ephysium species happen to be vancomycin resistant, also referred to as VRE, but excellent activity against Staphylococcus aureus, either MSSA and MRSA. And of course, if you consider Visa and VRSA, by definition, they are, somewhat resistant to van. So Visa essentially means vancomycin has intermediate activity, whereas VRSA is just resistant to vancomycin. Whereas lipoglycopeptides have much more improved gram-positive activity, including activity against VRE, against vancomycin-resistant Enterococcus. Keep in mind that none of these agents have activity against gram-negatives or gram-negative anaerobes, although they do tend to be active against gram-positive anaerobes, such as Clostridia species, and they are not active against atypical agents. Now, one thing to keep in mind is that vancomycin has a relative short half-life, so it is dosed typically 2 or 3 times a day, and we're talking about injectable. These are all injectable drugs. We're not talking about the oral version of vancomycin. We're talking about injectable vancomycin. Whereas dalbavancin and oritavancin have a very long half-life, so typically more than 1 week of half-life, which makes these two agents ideal for patients who need long duration of therapy, because you can get 1 or 2 injections and the drug will stay in the system for several weeks. Whereas vancomycin, if somebody needs long duration of therapy, it's an injection, again 2 or 3 times a day, that makes it less convenient. Now, daptomycin, let's talk about the mechanism of action of daptomycin. Its class is cyclic lipopeptide. It binds to bacterial membrane in a calcium-dependent manner, followed by the oligomerization of antibiotic molecules within the cell membrane, which results in depolarization, loss of membrane potential, and cell death. So that's the mechanism of action. And when it comes to resistance, it's more likely to be encountered in enterococci than staphylococci. So, for the most part, MRSA is susceptible to daptomycin. It's really hard to find MRSA that would be non-susceptible to daptomycin. It's more common to find enterococci that might be non-susceptible to daptomycin. Now, something cool about daptomycin is the seesaw effect, which essentially means that as daptomycin MICs go up, in either staphylococci or enterococci, we can see that beta-lactam MIC go down. So it's kind of seesaw. As the MIC of one goes up, the other one goes down. And the mechanism of this effect is not clear, but this has some important roles because if there are situations where we are concerned about resistant develop, we could potentially combine beta-lactams and daptomycin, and the combination would be very effective, because if the organisms develops resistant to one, then it becomes more susceptible to the other one, and vice versa. So it's kind of like a seesaw, and this is not just unique to daptomycin. The same effect also applies to vancomycin. So if you were to combine vancomycin with a beta-lactam, there would be a seesaw effect expected, specifically for staphylococci and enterococci. So here's the spectrum of activity of daptomycin. Excellent activity for gram-positives across the board, and absolutely no activity against gram-negative organisms. So this is an antibiotic directed at gram-positives, including MRSA. So excellent activity against MRSA and all sorts of enterococcus, including VRE. So when we have vancomycin-resistant enterococcus, daptomycin would be one of the drugs that would have excellent activity. We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of glycopeptide, lipopeptide, and beta-lactam antibiotics. Now, given a patient with suspected bacteremia, let's recommend appropriate empiric therapy. Blood is considered a sterile site. There is no colonization of the blood. There is no defined microbiota for the blood or filtering organs. Specifically, the liver and the spleen have the role of filtering bacteria or organisms in general from the bloodstream. The liver specifically has a rapid response when it comes to filtration of the blood, whereas the spleen has a slow response in filtration of the blood. The definition of bloodstream infection is a positive blood culture plus signs and symptoms of systemic infection. Now, in general, it is possible for bacteria or other organisms to be in the bloodstream infection transiently, and then they get cleared out. So it's not necessarily an infection in the absence of systemic infections. Bacteremia specifically refers to the presence of bacteria in the blood, whereas fungemia refers to the presence of fungi in the blood. And Candida by far are the most common fungi causing bacteremia. So the term candidemia refers to the presence of Candida species in the blood. And lastly, viremia refers to the presence of viruses in the blood. And most bloodstream infections are monomicrobial, meaning they are caused by a single organism. And about 5 to 13% of all bloodstream infections are polymicrobial, referring to more than one species of organisms. Urogenital procedures may introduce E. coli as well. And we have infective endocarditis, which is an infection of the cardiac endothelium and can present as either acute or subacute disease. Most common causes of infective endocarditis leading to bacteremia is Staphylococcus aureus, Streptococci species, and Enterococci species, and rarely gram-negative organisms. Secondary bacteremia essentially means bacteremia as a result of another infection in the body. By far, the most common cause of secondary bacteremia is urinary tract infections. So E. coli and Enterococci, if they make their way into the blood from the urine, they can cause bacteremia. Next, we have respiratory tract infections that can lead to secondary bacteremia. Most common causes include Staphylococcus aureus, Enterobacterales, Pseudomonas, and Streptococcus pneumoniae. Next, we have intra-abdominal infections. Most commonly Enterococci, Enterobacterales, and Bacteroides fragilis, which is an anaerobic organism that can make their way into the blood. And rarely, severe skin and soft tissue infections can lead to bacteremia, most likely due to Staphylococcus aureus and coag-negative staph. Now, when exactly should you suspect bacteremia? Patients present with general non-specific signs and symptoms that indicate a systemic illness or infection. Most commonly, fever, chills, sweats, fatigue, and anorexia may present. Now, this could be due to many things, but also they can occur in patients with bacteremia. So clinical suspicion of bacteremia essentially is high when you consider SIRS criteria. So there are 4 SIRS criteria. One is the presence of fever or hypothermia. Second is heart rate of more than 90 beats per minute. The third criterion is respiratory rate of more than 20, or PaCO2 of less than 32. And last one is white blood cell counts of greater than 12,000 or less than 4,000. Or if we have a bandemia in the patient, meaning more than 10% of the white blood cell are in segs. Now, if the patient has 2 of these 4, they're considered SARS positive. And when you see that, the suspicion of bloodstream infection goes up. One thing to keep in mind is that it is common for patients to reveal a leukocytosis, meaning increased white blood cell, within 24 hours of initiation of glucocorticoid. So if somebody just started glucocorticoids and white blood cell went up, it's not reason to get a blood culture. Another thing to keep in mind is that people who have surgery, it is common for them to have fever in the next 48 hours after surgery, and that's not necessarily due to infection. It's just the inflammatory response to the surgical procedure. So keep that in mind. Now, if the patients are, if you are suspecting sepsis or hypotension or shock, typically people can consider bloodstream infection. Presence of indwelling catheter increases your suspicion of bacteremia. And other inflammatory markers such as C-reactive proteins, if they are elevated more than 10, ESR or procalcitonin, and there are other things that you can consider. In general, it is important to use your clinical judgment when you suspect bacteremia in patients before ordering a blood culture. Now, when it comes to fever, fever is not always due to infection. Of course, fever can be due to infection, but there are other sources of fever. For example, people with malignancies, cancer, can develop fever due to that. Autoimmune conditions can lead to fever. DVT, occasionally patients can develop fever as a result of that. There is a phenomenon called drug-induced fever. So there are certain classes of drugs that occasionally can lead to fever, specifically anticonvulsants, beta-lactams, minocycline, allopurinol, heparin, captopril, nifedipine, and ibuprofen have been associated with fever. Not in most patients, but a small portion of patients can develop fever. Now, drug fever mostly occurs after 7 to 10 days of drug administration, and it rapidly reverses once we discontinue those drugs. And upon rechallenge, the fever does occur within a few hours. And then, of course, there is a fever of unknown origin when we cannot really identify a source for the fever. So keep that in mind. So not everybody with fever necessarily has an infection. Now, blood culture is considered the gold standard for diagnosis of bloodstream infections. When counting number of positive blood cultures, it is important to know how blood cultures are obtained. A blood culture consists of a set of 2 bottles of blood. One bottle is for aerobic organisms and another one for anaerobic organisms. So the tests that are done in the microbiology lab, there are different set of tests done for aerobic and anaerobic. So there are 2 different bottles required to make sure that there are enough sample, specifically blood sample, to conduct those tests in the micro lab. Now, at least 2 sets, meaning 4 bottles of blood, is required, and each set needs to be from a separate site. And the reason for this is to really make it easier to interpret the results and rule out contamination. Because if you get all of the bottles from the same site, if the technique was not appropriate and led to contamination, but pretty much all 4 bottles will be contaminated. So it helps to get it from 2 different sites in order to minimize the risk of all samples being contaminated. So when describing positivity, the number of bottles positive will be described. For example, we say 1 out of 4 bottles positive for coag-negative staph, or we will say 2 out of 4 bottles positive for coag-negative staph. So that's essentially how these things are reported. Now, collection of blood cultures should not substantially delay the start of antimicrobial therapy, especially in febrile ICU patients. It is ideal to collect the blood before antimicrobial agents are started in order to minimize the risk of false negative, because just a single dose of antimicrobial agents will significantly drop the yield of blood cultures. However, again, this should not delay start of appropriate antimicrobials in patients. Let's discuss contamination of blood samples. So because blood cultures are commonly contaminated with skin flora, specific organisms may be contaminants. And the most likely contaminants are Coag-negative staph, Bacillus species, Micrococcus, Crinibacterium, Cutibacterium. So these are the ones that are more likely to be a contaminant. So what it means is that if you have 1 out of 4 bottles growing Coag-negative staph, you essentially conclude that it's a contaminant. But if you have 2 out of 4 growing Coag-negative staph, because you have 2 of the bottle growing, that's unlikely to be a contaminant. So you conclude that it's a true infection due to Coag-negative staph. Now, you only do that with these organisms. There are these other organisms that you never consider a contaminant. So Staphylococcus aureus, for example, because it's a deadly bacterium, if you only have 1 out of 4 bottles growing Staphylococcus aureus, you are obligated to treat it. You cannot count it as a contaminant, because if you happen to be wrong about the contaminant, Staphylococcus aureus can kill the patient pretty quickly. The same with the rest of these organisms here. So Streptococcus pneumoniae, group A streptococci, any of the gram-negative bacteria, Bacteroides, and even the fungus Candida species. If you have even 1 out of 4 bottles growing any of these, you should consider it bacteremia and treat it. Now, viridans, strep, and enterococci, these are tricky. So they may be true pathogen or they may be contaminant. It's really they are considered on a case-by-case basis, and typically infectious diseases physicians will be consulted for these to decide if it's a true infection or a contaminant. Now let's talk about management of bacteremia. So blood cultures before antibiotics are essential, if possible. So if even 1 dose of antibiotic can actually eradicate organisms from the blood sample, so it can actually reduce the yield. So it will be more likely that nothing will grow out of the blood culture. So it's important to get the blood cultures before initiating antibiotics. But I say if possible, because, for example, if it's taking too long for the, if the staff are not available to get the blood cultures, which is extremely rare, you don't want to delay antibiotics. So it has to be within reason. In general, you want to give antibiotics within 1 hour. But, if it's taking like 2 or 3 hours for someone to come and get the blood cultures, it's okay to give the antibiotics before blood cultures, because we don't want that to be, at the cost of harming the patient. Now, source identification. It's important to know how the bacteria got into the blood, right? So bacteria don't belong to the blood. So you need to identify the source. And that's important because we're going to talk about source control. Because without source control, you can continue to give antibiotics. Once you stop antibiotics, if you haven't removed the source, the bacteria will continue to come back. So it's extremely important to identify the source. So catheter-related bloodstream infections, which essentially would lead that to the fact that the catheter will have to be removed and replaced with a new one. You can so if there is a catheter in place, you suspect that is the source of the bacteremia, and the catheter tip, for example, can be cultured to see it grow something that matches the blood culture. Symptoms, you can use the symptoms to identify where in the body the bacteria are coming from. So for example, if there is pain, for example, if there is low back pain, you might consider that there might be kidney infection. So you can use the site of pain to identify where the infection is coming from. Or if there is inflammation in a certain location, perhaps maybe it's a joint, or anything that you can identify from the symptoms. Microbiological cultures of the site. So if there is a wound, for example, and you culture it and you grow something, and the same thing is growing in the blood, or if you have a respiratory culture and it's growing something that matches what's growing in the blood, that identifies the source of the bacteremia. And of course, sometimes you just cannot easily find the source, so you may need something like imaging to kind of show you, within the body if there are, processes that could be due to infection. And of course, you identify the source in order to have source control, so you remove the source if possible. For example, if there are extravascular devices such as central line or prosthetic joint, you essentially remove them if possible. And once the infection is treated, you can replace these. And sometimes they may require consultation of other specialties. For example, if someone has cardiac hardware, cardiology team may be needed in order to assess whether its removal is possible. And sometimes surgery is needed, so surgical debridement. So if surgically they need to go in there and remove dead tissue, any things like biofilm, which we'll talk about another day. But surgical debridement can also be helpful for source control. Once bacteremia is suspected, it is important to start early empiric antibiotics, ideally after getting the blood specimen for culture if possible. Empiric essentially means that we don't know what the actual organisms are, so we have to do our best guess to see which organisms we need to cover until the results of culture and susceptibility become available. Mortality significantly increases the longer antimicrobial therapy is delayed, especially if the patient develops hypotension. So the choice of empiric antibiotics depends on the source if known. For example, cover urinary organisms if a urinary source of bacteremia is suspected. Use broad-spectrum antibiotics if severe infection, for example, hemodynamically unstable, if someone has septic shock, as an example. Cover multi-drug resistant organisms if patient has history of multi-drug resistant organisms in the past year, or high local prevalence of multi-drug resistance. Use preliminary microbiological data. For example, when gram stain tells you that the organism is most likely to be a gram positive or a gram negative, you can use that information to use appropriate antibiotics. And of course, you can use rapid diagnostic test results when available. Then you can optimize therapy using PK/PD principles. Because we are talking about bloodstream infection, intravenous therapy should be started initially with empiric therapy. This is the best route to treat bacteremia, given the site of penetration is the blood, and IV therapy is 100% bioavailable. And then of course you can transition to oral therapy for select pathogen-directed therapy, which we will discuss shortly. When it comes to bacteremia, it is important to avoid a number of antibiotics because of PK/PD principles. These agents have either high volume of distribution, meaning that they will have high tissue penetration, leaving suboptimal concentrations in the blood, or essentially they only go to a specific site. For example, nitrofurantoin only concentrates in the urine, the same with colistin. Tetracyclines and tetracycline derivatives such as tigecycline have a very large volume of distribution, so you're going to have a very small concentrations in the blood. Oral phosphomycin and oral vancomycin also have low bioavailability. In fact, oral vancomycin is not absorbed. Now, a portion of patients with bacteremia may develop sepsis. The definition of sepsis is a syndrome of acute organ dysfunction due to a dysregulated host response to infection. So in this case, it will be bacteremia or bloodstream infection. We will use definition from sepsis 3, which is the presence or suspicion of infection plus 2 or more on the SOFI score. Septic shock is a subset of sepsis, and this is essentially where despite adequate fluid resuscitation, patients continue to have hypotension requiring vasopresses to maintain a mean arterial pressure of at least 65 millimeters of mercury, plus a serum lactate of at least 2 millimole per liter. Now again, in the case of bloodstream infections, not everyone with bloodstream infection will have sepsis, but a portion of these patients will have sepsis, and not everyone with sepsis will have septic shock, but a portion of patients with sepsis will have septic shock, and a portion of those patients will unfortunately die despite adequate treatment. Now here are some recommendations from the Surviving Sepsis Campaign guidelines for the management of sepsis and septic shock. So essentially, if patients present with hypoperfusion, we initially use fluid resuscitation with 30 milliliters per kilogram of IV crystalloids. And when it comes to crystalloids, we prefer balanced crystalloids such as lactated ringers instead of normal saline. And if the patient requires large volume of crystalloids, it is recommended to use albumin in these patients. And essentially, these patients, we want to target resuscitation to maintain a MAP of over 65 millimeters of mercury. Now, if despite fluid resuscitation, the patient does not achieve MAP of 65, that is when we go to vasopressors. So norepinephrine is the preferred vasopressor and should be used as first line. Now, if despite use of norepinephrine, the patient still has not achieved a MAP of 65, instead of intensifying the dose of norepinephrine, it is recommended to add a second agent, and the second agent should be vasopressin. And if norepinephrine and vasopressin combination still doesn't result in a MAP of 65, then a third agent, epinephrine, is added. And then, hopefully the patient at that point has reached a MAP of 65. And then at some point, hopefully you need to wean away from these agents, and the patient should be able to maintain a MAP on their own. But if there's vasopressors continue to be required, it is recommended to add IV corticosteroids, and most commonly hydrocortisone 50 milligram IV every 6 hours is used. There are other recommendations, such as of course these patients will need pharmacological VTE prophylaxis, and that's also true outside of the ICU. For hospitalized patients with sepsis, they need pharmacologic VTE prophylaxis. If the patients happen to have a glucose of over at least equal or greater than 180 milligram per deciliter, it is recommended to initiate insulin therapy. And for patients who can be fed enterally, it is important to start early enteral nutrition within 72 hours. Now, the timing of initiation of antimicrobial agents are important, especially when patients have sepsis or septic shock. So if septic shock is possible, or if there is a high likelihood of sepsis, it's recommended to administer antimicrobials within 1 hour of recognition. If sepsis is possible without septic shock, that window is 3 hours. So, it's recommended to administer antimicrobials within 3 hours of recognition. And if there is low likelihood of infection without shock, then it is recommended to actually defer antimicrobials while closely monitoring the patient. The next thing to consider is whether MRSA coverage is needed. If there is a high risk of MRSA, it is recommended to use empiric antimicrobials with MRSA coverage, whereas if there is low risk of MRSA, there is no need for that empiric antimicrobial therapy to include MRSA coverage. Now you might ask, what would be considered high risk of MRSA? In general, prior history of MRSA infection or colonization in the past 12 months is considered, and recent IV antibiotics, typically in the last 90 days, is a risk factor for MRSA. And there are other things that the guidelines mention, such as history of recurrent skin infection or chronic wounds, presence of invasive devices, hemodialysis, recent hospital admission, or severity of illness. And then the last thing to consider is whether the patient needs double gram-negative coverage. And this is essentially for multi-drug resistant organisms such as Pseudomonas or drug resistant Enterobacterialis or other non-fermenting organisms such as Acinetobacter. So if there is a high risk of multi-drug resistant organism, it is recommended to use 2 antimicrobials with gram-negative coverage empirically. So, essentially this usually translates into having 2 agents with pseudomonal coverage. Whereas, once the results of the culture and susceptibility are available, then we can switch to just 1 antimicrobial based on the results. So this is the 2 antimicrobials is just for empiric period. And then for patients with low risk for multi-drug resistant, there is no need for double gram-negative coverage. Just a single agent is sufficient. Now, what's considered high risk for multi-drug resistant? It's proven infection or colonization with antibiotic-resistant organisms within the previous 12 months. And you can also use local prevalence on antibiogram, for example, to see if there is a high risk, high antibiotic resistant rate. Other risk factors that the guidelines list include nosocomial infections as opposed to community associated infections, broad spectrum antibiotic use within the last 90 days, concurrent use of selective digestive decontamination, travel to highly endemic country within the last 90 days, or hospitalization abroad within the past 90 days. As I mentioned previously, the blood culture is the gold standard for diagnosis and management of bloodstream infections. Now, you will see that from the time the patient is admitted or is at the emergency department when they present, it typically takes about a day or 2 until the gram stains give us some clues about what the patient might have, and then it takes about 2 days from presentation to identify the organisms, and then another 2 days. So it will be another day. So it will be at day 3 at minimum that susceptibility results become available. So it takes some time to know if the patient is on appropriate antibiotics, and if the patient is not, that essentially means that there has been 3 days that the patient was on inappropriate antibiotics. In other words, if something was resistant to it. So that's where the rapid diagnostic tests come in, because within the first day of the patient presenting, so typically within the first 12 hours, there's a good chance that rapid diagnostic tests can catch what the patient has, if it is one of the common organisms causing the infection, and guide us in optimizing therapy with appropriate treatment. So most commonly, BioFire BCID2 is available for blood cultures, and it can catch the most common causes of bacteremia, so Staphylococcus aureus and some of the gram negatives, including Enterobacterales, and also tell us about resistance if it happens to be there, so that we can intensify treatment. There is also Verigin that's essentially doing the same thing. It may take a little longer, and there are other PCR rapid diagnostics that are available that are extremely helpful in managing bloodstream infections. We described the common mechanisms of bacterial resistance and explained the mechanism of action of beta-lactams. Given a patient case, we recommended effective drug therapy for the treatment of bacteremia. Now, let's change empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. When susceptibility results become available, therapy must be changed to a more narrow spectrum agent based on those results. Now, occasionally, escalation is needed if the organism is resistant to what we were using as empiric therapy. Now, while initially IV antibiotics are required for treatment of bacteremia, oral antibiotics can be considered, especially those with good bioavailability more than 90%, and preferably the ones that have clinical data to support use. Most clinical experience with oral antibiotics is for gram-negative bacteremias. With gram-positive bacteria, because of a more serious complications such as endocarditis and difficulty to eradicate due to formation of biofilm of gram-positive organisms, especially with Staphylococcus and Enterococcus species, IV antibiotics have historically been recommended for the entire duration of therapy. However, recent clinical trials such as the POET trial that included patients with endocarditis suggest that oral antibiotics may be used for gram-positive bacteremia as well. Let's take a look at available options for definitive treatment of MSSA bacteremia. So we have a lot of antibiotics that have in vitro activity against MSSA, for example, vancomycin, nafcillin or oxacillin, which are anti-staphylococcal penicillins. So these are similar to methicillin. Cefazolin, which is a first generation cephalosporin, ceftriaxone, which is a third generation cephalosporin, and piperacillin tazobactam, which is also in the penicillin class. Now, the standard of care for treatment of MSSA bacteremia is to start with IV antibiotics. So all of these agents are available as IV only. And when you compare these, you will see that vancomycin is associated with nephrotoxicity. So is nafcillin and oxacillin. Nafcillin's more than oxacillin, but regardless, both of them are associated with nephrotoxicity, whereas cefazolin is not associated with nephrotoxicity, neither is ceftriaxone. Piperacillin tazobactam has also been associated in observational studies with nephrotoxicity. Now, with hepatotoxicity, specifically elevation of transaminases such as ALT and AST, you will see that nafcillin or oxacillin significantly increase transaminases, whereas the rest of these do not significantly increase transaminases. And when it comes to cost, most of these are pretty affordable with the exception of nafcillin or oxacillin. So these are pretty expensive in the range of hundreds of dollars per dose. So between $100 to $200 per day. Now, what we have seen in observational studies, and this is because we do not have head-to-head randomized controlled trials to compare these. So what we have is observational studies, is that nafcillin or oxacillin are actually superior to vancomycin in regards to clinical outcomes. So vancomycin is actually inferior to these as well as cefazolin, whereas cefazolin, nafcillin, or oxacillin have similar efficacy. And of course, you will see that the advantage goes to cefazolin because it is better tolerated, so it's less likely to cause nephrotoxicity and hepatotoxicity, and it's more affordable. And also the dosing is more convenient. So this is 2 grams IV every 8 hours, so only 3 times a day, whereas nafcillin and oxacillin need to be given every 4 hours, or you can do the entire 12 grams as a continuous infusion. So, pretty much around the clock. So that's inconvenient. Now, historically, nafcillin or oxacillin have been considered the standard of care for MSSA bacteremia. However, in recent times, cefazolin has become a better option. So, cefazolin, pretty much everything that you look at has a better profile compared to nafcillin or oxacillin. Now, there are other beta-lactams that also have activity against MSSA bacteremia, for example, ceftriaxone and piperacillin tazobactam. And a lot of patients may be on these agents empirically, but when the culture results come back and it is MSSA, it is important to switch the patients to either cefazolin or nafcillin or oxacillin, because again, based on observational studies, both ceftriaxone and piperacillin tazobactam had inferior effectiveness compared to cefazolin or nafcillin or oxacillin. MSSA bacteremia needs to be treated with IV antibiotics. Obviously, the site of infection is in the blood, so IV administration will take the antibiotics directly to the site of infection. The question is, once the patients start to improve, can we transition from IV to PO? And some experts do not recommend oral step down as a routine practice, and this is primarily because the evidence for IV to PO transition is based on observational studies. However, in 2024, the Sabato RCT was published. This study evaluated oral trimsulfa or clindamycin after 5 to 7 days of IV antibiotics in uncomplicated Staphylococcus aureus bacteremia, and in the study 92% of patients had MSSA and 8% had MRSA, so this is essentially applicable to MSSA bacteremia. And this was done in patients who were hospitalized due to Staph aureus. These are patients with low risk for complications, so this is uncomplicated bacteremia. And essentially after 5 to 7 days of antibiotics, patients were randomized to either receive oral antibiotics or continue IV therapy. And the primary outcome was 90-day Staph aureus bacteremia related complication, which was a composite of relapsing bacteremia, deep-seated Staph aureus infection, or mortality. And what they found was that in the oral switch group, 13% of patients had the primary endpoint of complications within 90 days compared to 12% in the IV group. And this was a non-inferiority trial with a non-inferiority margin of 10%. And it was essentially able to show that oral switch was non-inferior to continuing IV therapy. Now you can see the results for other outcomes, including the components of the composite. Of importance is death due to Staph aureus bacteremia, and you will see that this was also non-inferior. So although 2 people died in the oral switch, there was no significant difference between the 2 groups. In other words, oral switch was non-inferior to IV. So this could essentially change current practice and allow for patients who have uncomplicated MSSA bacteremia to be transitioned to oral antibiotics, specifically either trimsulfa or clindamycin. Now let's take a look at pathogen-directed therapy for bacteremia. First, let's consider methicillin-susceptible Staphylococcus aureus or MSSA. So for MSSA, treatment of choice is either an anti-staphylococcal penicillin such as nafcillin or oxacillin or cefazolin. And these are considered first choice. They are all superior to vancomycin for definitive treatment of MSSA bacteremia because they have mortality benefit. So, if patients receive vancomycin for pathogen-directed MSSA bacteremia, they're more likely to die compared to receiving these. Now, cefazolin is first-generation cephalosporin, and compared to nafcillin and oxacillin, cefazolin is a much safer option. So both nafcillin and oxacillin are nephrotoxic. So, patients are more likely to develop nephrotoxicity compared to receiving cefazolin. In addition, nafcillin and oxacillin are more likely to be hepatotoxic. So they are more likely to result in increased AST and ALT, so transaminases. And when you look at the dosing, I haven't listed the dosing for these agents here. Cefazolin is dosed every 8 hours, whereas nafcillin and oxacillin are actually dosed more frequently, every 4 hours. So it makes it more difficult to administer. Cefazolin, much better option. Now, of course, if somebody cannot tolerate beta-lactams, then vancomycin would be an alternative option for them. For MRSA bacteremia, drug of choice is vancomycin or daptomycin. Vancomycin is historically more affordable than daptomycin, so people most often use vancomycin. Now that is based on directed cost of acquisition when you compare vancomycin to daptomycin. Now, if you consider that vancomycin requires therapeutic drug monitoring, so you essentially need to pay a pharmacist to basically get vancomycin levels and make adjustment. one could argue that daptomycin might be more cost effective. But regardless, either vancomycin or daptomycin would be treatment of choice for MRSA. And the reason linezolid is not considered drug of choice is because typically with MRSA we need to treat for at least 2 weeks. And linezolid becomes problematic when you treat for long periods because of adverse effects. So vancomycin and daptomycin are much better tolerated and they're considered drugs of choice. Now, however, everything we have listed so far is only available as IV. One advantage of linezolid is that it is available as PO. So it would make it easier when transitioning from IV to PO. Now, in general, with MRSA, for the most part, we treat the entire duration as IV. In the POET trial, no patient had MRSA. So although, there is some evidence for oral treatment of gram-positive bacteremia, none of those patients had MRSA. So, pretty much standard of care right now for MRSA, for the most part, is IV treatment. Now, for VRE, which is vancomycin-resistant enterococcus, vancomycin, of course, is no longer an option because this is resistant to it. So now you have daptomycin or linezolid. And, with VRE, you don't need to treat as, for very long times as we do for MRSA. So typically shorter duration of treatment. So, linezolid becomes an option. And when you compare daptomycin to linezolid, daptomycin might have an advantage because, for one, linezolid is bacteriostatic, but daptomycin is bactericidal, so has more potent activity. But also, daptomycin is easier because it's in normal renal function, it's administered once a day, whereas linezolid is typically twice a day. But on the other hand, again, linezolid has an oral option, whereas daptomycin doesn't. So, there are pros and cons, but regardless, both of them are considered treatment of choice for VRE bacteremia. And so these were gram-positives. When it comes to gram-negatives, one thing that's very important is treatment of ESBL bacteremia. And carbapenems are considered first-line treatment for ESBL bacteremia. In fact, meropenem was shown to be superior to piperacillin tazobactam in randomized controlled trial. So people were less likely to die if they were receiving meropenem compared to piperacillin tazobactam. So there's mortality benefit with carbapenem. So now they are considered first line for ESBL bacteremia. And cefepime should be avoided because of increased risk of mortality. And this is, regardless of susceptibility. So if the patient has blood cultures growing, let's say ESBL producing E. coli, and is susceptible to piptazo and cefepime as well as meropenem, we should avoid using cefepime even though it is susceptible, and we should avoid using piperacillin tazobactam, and we should use a carbapenem because of the mortality benefit. And lastly, other gram-negative organisms, considering they are not multi-drug resistant, because, there are other resistant scenarios that are beyond the scope of this lecture. So we will not cover carbapenem-resistant Enterobacterialis. I will refer you to IDSA guidelines for treatment of those infections. Multi-drug resistant Pseudomonas, Cinetobacter, and other multi-drug resistant organisms we will not cover in this lecture. So other gram-negative organisms that are pretty much easy to treat, things like a normal E. coli that's not resistant to multiple drugs, or even Pseudomonas that's not resistant to multiple drugs. So essentially wild-type gram-negative organisms. You essentially choose the narrowest agents based on susceptibility results and PK/PD properties, meaning you want to choose agents that have good concentrations in the blood. For example, you want to avoid tetracyclines in general, because tetracyclines have a high volume of distribution, meaning that they distribute throughout tissue, so very little concentration remains in the blood. So if your treatment if the site of infection is in the blood, you actually want the drug to stay in the blood and not go to other tissues. And things like doxycycline, tigecycline, these are antibiotics that do not achieve high concentrations in the blood and should be avoided. Now, for oral treatment of gram-negative bacteremia, there are certainly more data when it comes to oral IV to PO switch for gram-negatives. And in general, we want to use high bioavailability drugs such as fluoroquinolones and trimsulfa. So you can see trimsulfa and fluoroquinolones have high bioavailability. Now that's preferred. Occasionally, if the patient cannot get these, then and only then oral beta-lactams may be considered. But you do have to make sure that you give a high dose to make sure you get enough concentration in the blood. So these are pretty high dose. If you are to use amoxicillin, you want 1 gram every 8 hours, or if amoxicillin clavulanate, it's at least 875 milligram, ideally 1 gram PO every 8 hours. If it's cephalexin, 1 gram PO every 6 hours. Now these three are preferred if you are to use an oral beta-lactam, and there are less data for the other oral. So if it's best to avoid the other ones due to lack of enough studies showing that you could get enough concentration with cefdenier, cefodoxime, and cefadroxil. But if you cannot achieve, if the patient cannot get these other, you could potentially use this, but you have to make sure that you use higher doses than normally we use. So you want to optimize the dose. We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of glycopeptide, lipopeptide, and beta-lactam antibiotics. And given the patient with suspected bacteremia, including sepsis and septic shock, we recommended appropriate empiric therapy, and we changed empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. Now, let's select total duration of therapy for bacteremia based on causative organism and patient characteristics. First, let's consider the role of follow-up blood culture. Of course, the initial blood culture is used to diagnose bacteremia. However, occasionally, based on the causative pathogen, we need to document clearance of the organism from the blood. So therefore, there is a need for follow-up blood culture to make sure that there is a negative blood culture based on the treatment. Specifically for Staphylococcus aureus, Staphylococcus lugdunensis, which is a coag-negative staph, and specifically for patients who have deep-seated infections and patients who have prosthetic devices in their body, it is important to document clearance with the follow-up blood culture to make sure that there has been sufficient source control and there is low risk of persistence or recurrence. In addition, there is a need for follow-up blood culture if there is a lack of clinical improvement or if the patient deteriorates despite treatment. That could mean, essentially persistent bacteremia or lack of source control. And there is an algorithm that you can take a look at in order to understand the process more. And essentially, this goes over what I simply summarized here. And you might wonder why not just get the follow-up blood culture for everyone to document clearance. And the reason is that unnecessary blood culture is associated with increases in hospital length of stay, antibiotic use, and other lab testings, and they may lead to anemia, patient discomfort, at adverse events. So therefore, we want to minimize or eliminate unnecessary follow-up blood cultures. So in general, for most gram-negative bacteremia where the patient is improving, people clinically typically do not get a follow-up blood culture to document clearance. Now let's talk about Staphylococcus aureus bacteremia, because not only The rate of mortality is typically 20 to 25% in patients with Staph aureus bacteremia, but also Staph aureus is notorious for having recurrence or persistence in patients. So it is recommended to repeat blood cultures every 1 or 2 days until we have a documentation of a negative blood culture. And in fact, for Staph aureus bacteremia, the very first negative culture marks the first day of treatment. So we actually do not count any days of antibiotics prior to that first negative culture. So if we say, this patient needs to get, this many days of treatment, day 1 is starting on the day that we have a negative culture. Now, it is important to classify bacteremia based on complications. So uncomplicated Staphylococcus aureus bacteremia, the recommendation for treatment is at least 2 weeks of either vancomycin or daptomycin. These are drugs of choice for Staphylococcus aureus bacteremia, specifically for MRSA. So this is for MRSA, vancomycin and daptomycin. For MSSA, we should be using beta-lactams active against MSSA. The reason these are listed here because these recommendations are coming from IDSA guidelines for MRSA specifically, and for duration of treatment we extrapolate these recommendations to MSSA bacteremia as well. So for MSSA, just ignore these agents, but the important thing is the duration of treatment. So we want at least 2 weeks of treatment for uncomplicated Staph aureus bacteremia, whether it's MSSA or MRSA. And the way we define uncomplicated is that essentially we want to exclude these 5 things. So we want to make sure that the patient does not have endocarditis, and the patient does not have implanted prosthesis, and we want to make sure that there is a follow-up blood culture performed on specimens obtained 2 to 4 days after the initial culture positive that is negative. In other words, if on day the initial blood culture is positive and then 5 days later is still positive, and on day 6 the blood culture is negative, then it's considered complicated. So you want to get your first negative culture within 2 to 4 days of the initial culture. The 4th category is defervescence within 72 hours of initiating effective therapy. Defervescence essentially means resolution of fever. And the last one is no evidence of metastatic sites of infection. In other words, making sure that the bacteria, Staph aureus, from the blood has not gone to other sites in the body and caused other secondary infections. Otherwise, if the patient doesn't meet the criteria for uncomplicated bacteremia, then the patient has complicated bacteremia. And for complicated Staph aureus bacteremia, they need at least 4 weeks of treatment, depending on the extent of infection. So how do we decide 4 weeks, 5 weeks, or 6 weeks? So essentially, as the patient approaches 4 weeks, it's based on clinical judgment to see how well the patient is improving. And then if the patient is not improving, longer duration of therapy may be required for the patient. Now, these are specifically for Staphylococcus aureus bacteremia, not for other types of bacteremia. For gram-negative bacteremia, because these are less likely to persist, the duration of treatment tends to be shorter. In general, a total of 7 days of appropriate antibiotic therapy for patients with uncomplicated gram-negative bacteremia who have achieved source control, are afebrile for at least 48 hours, and are hemodynamically stable, especially patients with a urinary source of bacteremia caused by Enterobacterales. Otherwise, the patient may need 14 days of treatment, especially if it's a non-fermenting gram-negative organism such as Pseudomonas or Acinetobacter. And essentially, complication is the definition of complication is similar to what we have for Staphylococcus aureus. So if someone has endocarditis, deep-seated infections, or if they have hardware, essentially they will be considered complicated. The only thing that's not done for gram-negative is that we don't typically get a follow-up culture to document clearance. Although if you do, it would be a good practice, but it's not routinely done. So to summarize, when it comes to duration of therapy, so you consider, for gram-positive MSSA or MRSA, if it's uncomplicated, you do at least 2 weeks. And, again, use clinical judgment. If the patient is not improving at 2 weeks, you, of course, want to extend the duration of therapy. And for Staph aureus specifically, the 2 weeks starts from the first negative culture. And if it's complicated, you do at least 4 weeks from the negative culture. For gram-negative organism, if it's due to wild type Enterobacterales, wild type meaning, it's not developing resistance to antibiotics, 7 days in uncomplicated bacteremia. Otherwise, if the patient has complicated or if it has resistant Enterobacterales, you do 14 days. And then for lactose non-fermented, whether it's complicated or uncomplicated, we want to do 14 days. And you might ask, what if you have bacteremia due to other causes? So perhaps Enterococcus or Streptococci. Those are less common, and there is less evidence for specific recommendation for duration of therapy. So we will not discuss those in this class. This concludes this presentation.